So yesterday I saw a 38-year-old female, mother of two, in finance, high functioning, saying, I'm exhausted all the time and can't sleep. I did a thorough history, and what she reported was she had trouble falling asleep. It would take her 1 to 2 hours a night. She would wake up all the time. She had racing thoughts at night. She was feeling tired during the day, but also had brain fog, irritability, and she was declining in her work performance. So what she was diagnosed with over the past 3 years by multiple providers was anxiety disorder. So she tried an SSRI, then depression. So they increased the dose of the SSRI. Burnout. She was told to take a vacation. She was told she's in perimenopause. So she was prescribed hormones. She told possible ADHD. So she tried a stimulant, which obviously made her sleep worse. So each provider focused on daytime symptoms, but no one formally evaluated her sleep. So what was she given? So she was given Ambien as needed, Klonopin nightly. They increased the Klonopin. Then she was started on trazodone. They increased the trazodone, and then they layered melatonin on top. And the result was temporary sedation. She had worse sleep quality, growing dependence, increased frustration. She wasn't feeling refreshed. So what was missed? She was never asked many questions. How long does it take you to fall asleep? What happens in your body when you try to sleep? How do you feel about sleep? Do you fear the night? No one assessed any of these things. No one asked about conditioned arousal, sleep-related anxiety, hypervigilance. So no insomnia patterns were actually identified. So when she finally saw me, took a full sleep history, we identified a lot of things like clock watching, anticipatory anxiety at sunset, her muscle tension in bed, the negative thoughts about poor sleep. And she had a normal sleep study. She had 2 normal sleep studies. I don't know why anyone thought a sleep study was needed. That's incorrect. So the correct diagnosis was chronic insomnia disorder with hyperarousal type. Very, very common in the population. It wasn't anxiety. It wasn't depression. It was not hormonal. It definitely wasn't ADHD, and it wasn't just stress. So what did? We did some CBTI, some stimulus control. We restructured her thoughts about sleep and the threats of sleep. We tapered and deprescribed her meds. And now we're working on building her sleep confidence, and she has an individualized pharmacological plan that works for her type of anxiety. All too common. Just another day in the office, I tell you. Just another day in New York City.